Prostate Pathology, Staging, and Pharmacology Rapid-Fire Clinical Review. A 53-year-old asymptomatic male patient is in for a routine health screening. His serum prostate-specific antigen level comes back at 18 nanograms per milliliter. Now, on his digital rectal exam, his prostate is completely smooth, no nodules. What's the most appropriate next step in the management of this patient? Option A, initiate immediate external beam radical radiotherapy. Option B, perform a transurethral resection of the prostate. Option C, arrange for a transrectal ultrasound-guided prostate needle biopsy. Option D, proceed directly with an open radical prostatectomy. Or Option E, prescribe a course of systemic cytotoxic chemotherapy. The correct answer is C, transrectal ultrasound-guided biopsy. Look, a serum PSA level greater than 10 is a massive red flag for prostate malignancy. Even if that DRE feels completely normal, you absolutely need a tissue sample to nail down the diagnosis. So, the standard next step is a TRUS biopsy, where you systematically take at least 12 core samples from different zones of the prostate under local anesthesia. For your exam pearls, any asymptomatic patient with a stable PSA greater than 10 or a highly abnormal nodular DRE mandates a needle biopsy to screen for cancer. But don't forget your PSA modifiers. PSA can definitely spike from non-malignant issues. Think acute urinary retention, acute prostatitis, a recent cystoscopy, or even a really vigorous digital rectal exam. A 62-year-old male presents to the urologist with moderate lower urinary tract symptoms, yielding an international prostate symptom score of 15 out of 35. On digital rectal examination, hard asymmetric nodules are easily palpated bilaterally, and the overlying rectal mucosa is fixed. What's the most appropriate next step to simultaneously relieve his mechanical obstruction and confirm a suspected malignancy? A. Arrange for a course of radical pelvic external beam radiotherapy. B. Perform a therapeutic transurethral resection of the prostate and send the tissue for histopathology. C. Order an outpatient transrectal ultrasound-guided needle biopsy alone. D. Proceed directly to an elective radical prostatectomy. Or E. Send the patient for a microscopic urine culture and sensitivity assay. The correct answer is B, TURP and biopsy. This patient presents with a highly abnormal digital rectal exam, stony hard nodules, and fixed mucosa, which is clinically diagnostic of advanced locally aggressive prostate carcinoma. Because he's also dealing with active bladder outlet obstruction, indicated by that IPSS of 15, a therapeutic and diagnostic TURP is your ideal intervention. It immediately debulks that inner transition zone to relieve his mechanical urinary retention, while simultaneously providing a large volume of chipped tissue for formal histopathological grading and staging. The key exam pearl here is the dual-purpose TURP. In a patient presenting with both urinary retention and a highly suspicious malignant DRE profile, an endoscopic TURP serves a vital dual therapeutic and diagnostic role. Which of the following bones is the most frequent site of hematogenous metastatic deposition in advanced progressive carcinoma of the prostate? A. Pelvic bone. B. Thoracic ribs. C. Skull. D. Proximal femur. Or E. Lumbar spine.
The correct answer is E. Lumbar spine. While the primary lymphatic drainage of prostate cancer targets regional pelvic lymph nodes, its hematogenous spread shows a massive affinity for the skeletal matrix. Malignant cells actually travel retrogradely from the prostate directly through the valvulus batsins vertebral venous plexus and straight into the lumbar vertebrae. The skeletal distribution hierarchy steps down exactly like this: lumbar spine first, then the proximal femur, pelvic bones, thoracic ribs, sternum, and finally the skull. As an absolutely crucial clinical pearl, skeletal metastases from prostate cancer are characteristically osteoblastic. They produce these dense, white, sclerotic lesions on plain films because the tumor stimulates local osteoblasts. A staging evaluation for a patient with confirmed prostate adenocarcinoma demonstrates that the tumor has breached the prostatic capsule and directly invaded the seminal vesicles bilaterally. What is the correct clinical T-stage for this tumor? A. T2C, B. T3A, C. T3B, D. T3C, or E. T4.
The correct answer is C, T3B. Let's break this staging down. A T3 score denotes that the tumor has extended entirely through the prostatic capsule and out into the local extraprostatic soft tissues. T3A specifically means extracapsular extension without involving the seminal vesicles. However, T3B, exactly as described in our vignette, indicates direct tumor invasion extending into one or both seminal vesicles. Just to complete the picture, a T4 stage is reserved for advanced tumors that have directly invaded adjacent organs beyond the seminal vesicles, stuff like the bladder neck, external urethral sphincter, rectum, or the pelvic sidewall muscles. What is the gold standard definitive curative treatment option for a patient diagnosed with localized, organ-confined, stage T2 adenocarcinoma of the prostate who has a life expectancy of greater than 10 years? A. Radical prostatectomy. B. Single-agent cytotoxic chemotherapy. C. Adjuvant brachytherapy alone. D. Medical castration using continuous LHRH agonists. Or E. Bilateral surgical orchiectomy.
The correct answer is A. Radical prostatectomy. For a patient with a localized, organ-confined stage T2 prostate carcinoma who is otherwise fit and has a prolonged life expectancy well beyond 10 years, radical prostatectomy remains the gold standard curative treatment. This surgery involves taking out the whole shebang, the entire prostate gland, its capsule, the seminal vesicles, and regional pelvic lymph nodes. To map this out cleanly, locally confined disease, T1 and T2, is managed with curative intent via radical prostatectomy or radical external beam radiotherapy. Conversely, advanced or metastatic disease, T3 and T4, is managed palliatively with systemic androgen deprivation therapy. A 57-year-old male presents with a new onset of obstructive urinary symptoms and a recurrent urinary tract infection. He reports undergoing a successful TURP 5 years prior for a biopsy-confirmed diagnosis of benign prostatic hyperplasia. What's the most likely underlying pathology here? A. Late-stage clot retention within the bulbar urethra. B. Iatrogenic bladder sphincter incontinence. C. Recurrence of the primary hyperplastic tissue. D. Delayed bladder neck stenosis or stricture. Or E. None of the above.
The correct answer is C. Recurrence of primary disease. Looking at long-term data, a subset of patients who undergo a primary TURP will experience a late recurrence of benign prostatic hyperplasia, typically manifesting with renewed bladder outlet obstruction roughly 5 to 10 years postoperatively. This long-term failure is almost always driven by a technically incomplete primary resection. Basically, some hyperplastic transitional zone adenoma tissue gets left behind, and it just continues to grow over time under androgenic stimulation. Pay attention to the timeline comparison. A bladder neck contracture or stricture is an early postoperative complication that manifests rapidly, usually within 6 months of surgery. BPH recurrence, however, is a late, progressive complication creeping up 5 to 10 years after the primary procedure. During a traditional open transvesical suprapubic prostatectomy for severe BPH, what specific anatomical structure is systematically enucleated by the surgeon? A. Isolated resection of the lateral prostatic lobes only. B. The hyperplastic prostatic adenoma. C. The normal posterior lobe of the prostate. D. The entire prostate gland along with a small portion of the bladder trigone. Or E. The entire prostate, bladder, and proximal half of the urethra. The correct answer is B. The hyperplastic prostatic adenoma. An open transvesical prostatectomy is actually a finger enucleation procedure performed extraperitoneally, right through an incision in the lower anterior bladder wall. The surgeon manually shells out and enucleates the hyperplastic prostatic adenoma, which is that expanded transitional zone tissue, while leaving the normal peripheral zone and the outer prostatic surgical capsule completely intact. Here is your key indications pearl. This open procedure is preferred over an endoscopic TURP when the prostate is exceptionally large, meaning greater than 80 to 100 grams, or when the BPH is accompanied by large bladder pathologies that require a direct bladder approach, like a massive bladder diverticulum or calculus. A patient presents to a community health center with moderate bladder outlet obstruction and is diagnosed with benign prostatic hyperplasia. He started on an oral medical therapy. Literally the next day, he returns to the clinic complaining of severe dizziness, lightheadedness, and an episode of near syncope upon standing. Which of the following drug classes is responsible for these acute side effects? A. 5-alpha reductase inhibitors. B. Selective muscarinic antagonists. C. Loop diuretics. D. Alpha-1 adrenergic receptor blockers. Or E. None of the above. The correct answer is D. Alpha-1 adrenergic receptor blockers. Alpha-1 adrenergic antagonists, such as tamsulosin or prazosin, work brilliantly by relaxing the smooth muscle within the prostate's stroma and bladder neck to reduce dynamic bladder outlet obstruction. But here's the catch. Blocking those systemic alpha-1 receptors also induces peripheral vasodilation, which leads straight to acute orthostatic hypotension and dizziness, particularly following the first few doses. If we quickly compare BPH meds, alpha blockers work rapidly but carry those exact side effects of dizziness, postural hypotension, and retrograde ejaculation. In stark contrast, 5-alpha reductase inhibitors, like finasteride, take a totally different route. They physically shrink the prostate over about 6 months, but their side effects lean toward decreased libido and erectile dysfunction. A 55-year-old male with a history of alcohol use is evaluated for benign prostatic hyperplasia and started on an oral tamsulosin regimen. After several weeks of compliant use, he returns to the clinic complaining of a noticeable decrease in his semen volume during intercourse. What is the precise mechanism driving this specific side effect? A. Intrinsic primary hypogonadism. B. Permanent cavernous tissue fibrosis. C. Drug-induced retrograde ejaculation. D. Acute secondary testicular atrophy. Or E. Mechanical bladder neck stenosis.
The correct answer is C. Drug-induced retrograde ejaculation. Tamsulosin is a highly selective alpha-1A adrenergic receptor antagonist. Now, while its selectivity does a great job of minimizing that systemic orthostatic hypotension we just talked about, it heavily targets the alpha receptors localized right within the bladder neck and seminal vesicles. Relaxing the bladder neck prevents it from closing completely during ejaculation. So, instead of moving forward through the urethra, the semen travels retrogradely right into the bladder, which manifests as a decreased or absent semen volume for the patient. As a final clinical pearl, this ejaculatory dysfunction is entirely dose-dependent. You'll see it in about 11% of patients on a standard 0.4 milligram dose of tamsulosin, and it jumps to nearly 18% on a higher 0.8 milligram daily dose. Importantly, this side effect is completely reversible upon discontinuing the medication.